now for the myocardial infarction complications. Uh, we may have cardiac arrhythmia, and it happens in the first few days to several weeks. The findings, it can be supraventricular arrhythmia, so it is above the ventricle, or ventricular arrhythmia originating in the ventricles, or just a conduction block, that is the blockage of the signal transmission from the atria to the ventricles. All of these may end up or considered actually an arrhythmia, so it's a cardiac arrhythmia. So it happens due to myocardial death and scarring. It is an important cause of death before, this is too important, before reaching the hospital and within the first 48 hours after the happening of the myocardial infarction. So we'll see later that there is another reason for the death to happen after the patient who develops MI, myocardial infarction, goes to the hospital. So if it's before the hospital, then most likely the death is due to the cardiac arrhythmia, and it happens in the first 48 hours post myocardial infarction. So we have also peri-infarction pericarditis. It happens within 1 to 3 days. The patient may develop pleuritic chest pain, pericardial friction rub, something that we can hear on auscultation, and EC changes, of course, and or small pericardial effusion. So it's not huge, it's just a small pericardial effusion. This is usually self-limited. It goes on its own, while papillary muscle rupture, it happens within 2 to 7 days. It can result in acute mitral regurgitations because the papillary muscles are the tiny muscles that attach the mitral valve to the wall. So if they do rupture, then the mitral valve is not functioning as it used to because it's not as secure as it used to. So we may develop a mitral regurgitation that may end up as cardiogenic shock and severe pulmonary edema because the valve is not working or functioning fully as it was. So that definitely may lead to complication, cardiogenic shock and severe pulmonary edema. For the nose, it's posterior medial, most likely the place for its occurrence, and it happens more than the anterolateral papillary muscle rupture. So if it's posterior medial, then it occurs much more than, or expected much more than, the anterolateral papillary muscle rupture. That is in image A. So there you go. The yellow arrows. As well, I think that's supposed to be over here. There's supposed to be some papillary muscles attached, like these are the normal attached ones. So we should see those over here, but we're not seeing these anymore. So this is a rupture. Now, as the posterior medial has single artery blood supply, that is the PDA, whereas the anterolateral has dual, that is left anterior descending, and then the left circumflex artery. So what is happening? Why does it always or most likely affects the posterior medial part of the papillary muscle? Because the posterior part, the posterior medial part, has only one coronary artery supplying it, so it's less strong or less tough than the anterior lateral, because the anterior lateral has two blood supplies. So whatever happens to one of those, the other one is still supplying. So the anterior lateral part is really secure, is really tough because it has two supplies, while the posterior lateral unfortunately only has one. So anything happens to that one, then it will affect the posterior medial like majorly. So now for the interventricular septal rupture, that is the septum between the two ventricles. Okay, so it happens in 3 to 5 days. Sometimes some symptoms range from mild to severe cardiogenic shock and pulmonary edema. For the notes, it's caused by the macrophage mediated degeneration. We know that the after the myocardial infarction, the most likely thing to happen that is causing degeneration is that the macrophages do go to that site and eat the extracellular matrix and causes the degeneration. That may end up because it's the septum between the two ventricles. This is the left ventricle, this is the right ventricle, these are the atria over here. So it's this part that we're talking about. So if it gets eaten over here, if it ruptures, then we have developed VSD, that is a ventricular septal defect, and that will increase the O2 saturation and the pressure in the right ventricle, which is not expected because we know that left ventricle has a high O2 concentration because this is oxygenated to the blood. So if there is a small tiny rupture over here that is allowing the blood to pass to the right ventricle, then now the right ventricle is starting to have high O2 concentration and pressure due to this rupture. So we also have the ventricular pseudoaneurysm. So this is not a real aneurysm, and it happens within 3 to 14 days. It may be asymptomatic symptoms, but if it's symptomatic, then symptoms include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus, and it may end up rupturing. So that would lead to cardiac tamponade because it's allowing for the fluid or blood in this case to surround the heart under the pericardial covering. So the free wall rupture contained by adherent pericardium or scar tissue. So if we do have a free wall rupture, like there is a huge or big or even a small like rupture within the muscular wall of the heart, that means the fluid is just getting out to the outside, but not fully to the outside because it's already covered or adherent or controlled by the pericardium of or a scar tissue if there is a previous myocardial infarction. This or the same myocardial infarction. It does not contain endocardium or myocardium because this is a pseudo. As I said, it's a pseudo aneurysm, so it does not involve the endocardium or myocardium, and more likely to rupture than the aneurysm. Like this, even though it's pseudo, then it's more likely to end up rupturing than the actual true aneurysm. And if we take a look at image B, so this is a free wall rupture, and this is blood going to the outside, but it's not fully to the outside because it's already contained within this cover, the pericardial cover. So this is the ventricular pseudo aneurysm. Now we have the ventricular free wall rupture. It happens 5 to 14 days. Free wall rupture as an image C. So there you go. There is a whole huge opening within the wall of the ventricle. So this is the ventricle and it's not contained as we see. So of course blood is leaking to the outside, as I say. So free wall rupture, it causes cardiac tamponade because blood is actually going to the outside. But of course we know that there are many layers surrounding the heart. So as it says, we have here the pericardium. It's the um, outermost layer of the heart, so it's also containing uh, the blood now, so that would end up as cardiac tamponade. Acute form usually leads to sudden death. If it's acute, then not like small leakage, it's acute and sudden, then it may end up as sudden death. The notes, it says that left ventricular hypertrophy and previous myocardial infarction, they protect against the free wall rupture. Okay. For the true ventricular aneurysm, then it happens. Okay, so let me say this: if for left ventricular hypertrophy and previous MI, they protect against the free wall rupture because if we have left ventricular hypertrophy, that means the width of the wall of the ventricle is larger, so it's hard for the wall to rupture like fully. And if it's previous MI, we may develop in that previous MI a scar tissue, and that scar tissue is an extra protection against rupture, so it doesn't rupture easily. So for the ventricular, true ventricular aneurysm, it happens 2 weeks to several months. It is similar to pseudoaneurysm. The symptoms may include chest pain, murmur, arrhythmia, syncope, heart failure, embolus from mural thrombus, and the rupture as well may end up as cardiac tamponade. So So it is an outward bulge with contraction dyskinesia, and it's associated with fibrosis. So it well, it looks like there is a bulging to the outside of the myocyte of the myocardial wall with contraction. So in order to maintain stabilization, so there is dyskinesia in that area, and then it's associated with fibrosis. For the post cardiac surgery injury syndrome, it happens weeks to several months, and it's fibrous pericarditis due to autoimmune reaction. So that, let's say, look at the name actually, it's post cardiac injury syndrome. So it's a fibrinous pericarditis. So I guess it's an inflammation of the pericardium with a fibrosis occurring at the same time. So, but that happens due to autoimmune reaction. This is what is called. We talked about previously. It's the Dressler syndrome. It's the cardiac antigenes released after injury. They cause the deposition of immune complexes in the pericardium, which ends up as inflammation because the body's immune system doesn't actually know that this is only the normal cardiac antigens, and deals with the cardiac parts and cardiac um, stuff as antigens, and starts releasing some immune complexes that go into the heart and deposit in the pericardium, and of course that leads to inflammation because it's the immunity system that is acting now. And that should be it.